Hi everyone, I hope you guys are doing well. This is chapter 9 and it will be the last set of slides I put up for our next test. The next test will be on, as I said earlier, chapters 9, 10, and 11. So make sure you take the time to go through these slides, fill out your study guides that you have at home with you. Make sure you pay attention to any other things that are on the top of your study guide that you need to be studying, such as abbreviations, any type of key terms. It's very important that you guys study your Appendix A, and I will be talking to you soon about turning in your case study number 2. So if you haven't completed that yet, your case study number 2, start working on that now. Also, we will be looking at taking our next lab test. We had pretty much finished up everything in lab. We just had some venipuncture stuff that we were going to do, but I'm going to update y'all on that soon. We were still working on the labs that were for labs 13 through 16, which were chapters 7 and 8. So you guys, while we were in class before we went to spring break, you should have already read chapter 7 and 8 in your white lab binder and started filling out your study guides there for those. So make sure that you're doing that as well, because I'm hoping that we will be able to salvage labs some kind of way so you guys don't end up with an I of any sort and have to repeat that, and which would put everything off. So we can all cross our fingers so that there is something that we'll be able to do in the late summer that will get you guys on track for completing both your lecture in phlebotomy and your lab in phlebotomy. So again, right now, what I need you to focus on is look at your case study number 2 and start filling that out, which you should have been doing that already during the break, okay? And we're going to turn those in soon, but I'll give you time to fill them out. Also, make sure that you're looking at the slideshows for this chapter, chapter 9, chapter 10, which is already up, and chapter 11. Fill out your study guides and start studying. And make sure you're looking at Appendix A in your book as well, because that information is useful, okay? Not only are you going to need it for this class in both lab and lecture, and you see it come up on our test over and over again. What are the 4 tests that are in, what's in an electrolyte profile, right? You've seen this more than once. So make sure you're studying those, your tube color, your order of draw, what's in your chemistry profiles and panels, what's in your CBC, all those things. You guys have got to be practicing that and get it down, because you'll need it for this class. You'll need it for Allied Health 211. You'll need it when you go out and do your clinical rotations. You'll need it when you sit for your registry, and you'll need it when you go to work. So please make sure you're doing that, and I'll get with you soon on how we're going to move forward in lab, because what I'd like to do is keep us as close on track as humanly possible so we don't have to repeat anything. Also, look at case study number 2, because we'll be talking about that soon. Again, I'm not going to read everything on these slides. I'm going to go through them. I'm going to highlight the high points. You guys fill out your study guides. If you have any questions, comments, or concerns, please feel free to reach out to me by email, okay? And we'll work through this. So again, these are our learning objectives. So the basal state, okay, that's the first thing we're going to talk about. And the thing we need to understand about the basal state is this is first thing really, really early in the morning, okay? After you've been asleep for a while, you wake up, but you haven't moved around a lot yet. You haven't gotten out of the bed. You haven't gone to the restroom. You haven't done anything yet. That is the basal state, okay? And we like to draw our labs while patients are in the basal state strictly because the normal values that we have come from people being in that basal state. So we like to compare apples to apples when we can. Also, we've talked about fasting, right? But we understand that when we are talking to a patient, and this will be part of your job as a phlebotomist, to explain to patients what fasting is when it comes to their lab results. which may differ from from fasting before surgery or fasting for another procedure that is not lab. Okay, so you need to make sure that they understand that they're not supposed to get any food or beverages. You also want to make them understand that they don't need to smoke, they don't need to chew gum. And a lot of people think that they can drink unsweetened beverages like coffee with nothing in it or tea with nothing in it, and that's just not true. Okay, now there's other people out there working, nurses and radiology technicians and people like that, that may give people information on fasting, and they may ask them to abstain from even drinking water, okay, especially before surgery. But we don't do that because we don't want them to be dehydrated when we stick them. It's going to make it harder on us and harder on them, okay? Don't get hung up on that hours. You know, you can see, sometimes you'll see 8 to 10, 8 to 12. You can kind of see where that's in that ballpark, okay? And you have to make sure that if that patient is not fasting, then you need to write non-fasting on that requisition or specimen so that doctor will be aware. And we realize that the most common tests that are done, and we ask our patients to be fasting before they're done, are when we do lipid panels, when we do glucoses, cholesterols, triglycerides, tests like that are the ones that we really have to worry whether they're fasting or not. And a lot of times, most of those chemistry tests and chemistry panels, we prefer them to be fasting because most of them is going to have glucose or cholesterol or triglyceride on that panel. There's very few of them that don't have at least the glucose on there, okay? And again, we want them to avoid chewing gum. We want them to avoid smoking and drinking coffee or tea, even if it doesn't have sugar in it, because it has been proven to cause fluctuations in their sugar levels. We talked about turbidity, and we looked at it in lab and lipemic specimens. This is usually where when you spin their blood down, the serum is really, really cloudy. Sometimes it'll look like milk if it's lipemic, and this is because they have eaten something that is very, very fatty, okay? And we need to document that so the physician is aware of it. Here's one of our thinking questions. As I told you in previous presentations, this is a really great time for you guys to pause this video, get a piece of paper out, and see if you're answering these correctly. See if you're putting everything you're learning in lab and lecture all together, and you're able to use it when you go out in the field so that you can be the best phlebotomist you can. If you run into any issues and you feel like you're not being able to put this stuff together for one reason or another, please, please, please reach out to me. We can solve this very easily, okay? So you'll be able to pause this and answer your question and see if you're getting close. Okay, and you'll see in here that a lot of times I do this for you guys to understand as well. Sometimes people don't understand why we want to draw blood at 4:30, 5 o'clock in the morning on patients. And it's because we're trying to catch people in a true basal state, okay? And the difference between the basal state and fasting, we're just talking about what they've consumed as far as drank or eaten after a certain amount of time. But in the basal state, we want them barely moving and have not gotten out of the bed, because we want to compare it to as close as we can to our normal values. So sometimes there's a method to the madness. I know sometimes people don't understand why we do the things that we do, but this is an explanation as to why. Okay, obviously we're not in class and we're not going to be able to do the learning activity as we would like to, but I'm sure there's someone in your house that you're with on a daily basis, possibly, hopefully, that you can do this with. So if you could do that, just find somebody in your household, your child, your mother, your significant other, pause it, explain it to them, and then go forward and see if you're doing this, you're getting everything that you need to get. Keep practicing it, because this is something that you guys will do out in the field, and I want you to be the best you can be at what you do, and I want you to be really knowledgeable so that when you go into Willis-Knighton, Oshner's, Minden Medical. You will impress these people with your knowledge and your ability to handle these situations so that when they have openings, they'll look to you to fill that opening. Okay, unfortunately, half of adult patients in the U.S. are overweight. And when you're dealing with a morbidly obese patient, it can sometimes turn into an issue being able to palpitate or even visualize their veins, which we don't find veins by visually looking at them, but you can't see them, you can't feel them. It turns into a really big problem. That's why a lot of times we're moving to hands. That's why a lot of times we can move to skin punctures, but sometimes we have no choice and we have to look for that vein. And as you work more and more with these types of patients, you start getting the hang of tricks and tips that you can do to find it. But we also want to make sure we never probe around in someone's arm. It's like I've told y'all before, small, minute movements, okay? And they do make needles. Most standard needles are about 1 inch long. If you see a needle that is approximately about 1.5 inches long, that's usually made for obese patients. So occluded, scoliosed, thrombi, burned, scarred, and tattoos. These are all things that can cause complications when we're drawing blood. If a vein is obstructed and the blood's not flowing through it, obviously that's going to cause a problem, and we want to avoid those types of things. If we have any type of, I know you guys have heard of hardening of the arteries, there's hardening of the veins due to inflammation. That makes it more difficult. We want to try to avoid that. Thrombi, those solid masses that are like blood clots in the veins. They're partially or fully occlude the vein. There's a small picture up there. There's also some pictures in your textbook. And then burned areas. They're very sensitive and they're very susceptible to infection. If you have a very badly burned patient, hopefully if they're burned on just one side, you can get the other arm. If they're burned on both sides, hopefully they have some type of line that someone who is authorized to draw out of that line can draw your specimens for you. And then because veins are scarred and they're a little more difficult to feel and to be able to feel which way they run or to palpitate and find them. And sometimes tattoos, they contain dye, obviously, and it can interfere with lab tests, and they can be more susceptible to infection and impaired circulation. So we do want to keep that in mind. Okay, so allergies. We all know that some patients, yourself, maybe someone you know is allergic to things like latex, right? There's also other things they can be allergic to. Sometimes things like iodine, alcohol, right? Chlorhexidine, okay, can be used as an alternative when decontaminating the skin if they're allergic to alcohol. So there's other things that you can do. We also have latex gloves now, latex-free tourniquets, bandages, all these types of things, and we want to pay strict attention to our patients to make sure that if they have an allergic reaction or if we know they're allergic to anything, we avoid using whatever it is that they may be allergic to. That's why that medical interview is good, because sometimes when you're talking to your patient, they will go ahead and tell you, hey, by the way, I'm allergic to latex, or hey, I'm allergic to iodine. So that's why it's good to talk to them. Okay, exercise and stress. Exercise is very good for you, okay? It's very good for you. But there's a difference between going out and walking 3 miles or going for a short jog for just a mile or two, not very fast, and going out and running a marathon or an Ironman, or, you know, just lifting very, very heavy weight. These are things that can change your lab results. And that's why we ask them, you know, we practice that in lab. We ask them, have they exercised very strenuously in the last 24 to 48 hours? Okay. So you always want to tell your patients, if they're coming back in for some lab work the next day or so or next week, always let them know, hey, don't do any real strenuous exercising before you come in to have that lab work done, okay? Stress is bad. As a matter of fact, going for a walk outside, going for a light jog or a run can really really help you lower your stress level, lower your anxiety level. And I know right now everybody's experiencing a lot of stress and anxiety, but these things can elevate your WBCs. They can decrease your serum iron, and you can have some abnormal hormone values due to really severe increased stress. So you guys, while you're home right now going through this COVID-19 thing, please make sure that you take the time to go outside, go for a walk. Try to still stay away from other people. But if you can find just a time of day in your neighborhood where you can get out and go for a walk, I know a lot of you are working with your children doing online classes. Make sure you take breaks. Make sure you get up and walk outside. The fresh air, listening to the birds, it will help decrease your stress right now. Okay, we've all heard babies, especially newborns, just crying violently, okay? We want to try to avoid collecting blood from these babies when they've been crying like that. We want to let them calm down if we can and wait about an hour before we draw their blood, because as you can see from this slide, their WBC count can go up 140%, okay? All right, and also we know that it can return to normal in about an hour. You can see that from the slide, so we want to make sure that we're aware of that and we take that in consideration. Sometimes we're put in a position where we have no choice, but we want to avoid that at all costs. Here's a thinking situation, okay? I want you to take everything you're learning so far and put it together so that you can critically think through situations that you may be faced with out in the field. Okay, so circadian or diurnal rhythms, right? Body fluids fluctuate during the day. Okay, things like your hormone levels, cortisol, TSH, T4, renin, all these things, insulin, all these things can fluctuate throughout the day. They can increase and decrease, okay? So changing from a supine position to a sitting or standing position causes body water to shift from intravascular to interstitial compartments in the tissue. And tests that must be drawn in that supine position are that aldosterone and that renin. So we need to understand that. We need to get our patients to lay down, right? Before we draw these tests, okay? And make sure that you're aware of which tests these are. Which test do you need to have drawn in the supine position? You know that's going to be on a test. No one should miss it. Here's another one of our thinking situations that we want to be able to put all this stuff together so that we can critically think through issues that we will face out in the field. Okay, travel issues affecting laboratory results. This is all about communication, okay? We need to understand what affects laboratory results, like when we talked about stress and exercise, and so that we can communicate these things effectively to our patients so that they can avoid doing these things before they have their lab work drawn, okay? So communicating with patients about any recent long distance travel. You want to avoid just erroneous results. These are results that are coming from the fact that they did this isolated thing, whether it was flying to Japan or Australia, or whether they were running a marathon or doing an Ironman. This is something that people don't do every day. So we want to make sure that when we're doing their yearly lab results, or we're testing for something that they've got ongoing issue that they've got going on, and we're monitoring them and treating them, that they're aware of these things that they do occasionally that can't interfere. So you want to have 5 days, or really what we need, to get back to a stable circadian rhythm after you've traveled across 10 time zones, okay? That's pretty long. That's like if you're flying to Australia or Japan. Okay, if you just flew to Dallas and back, it wouldn't be that big of a deal, okay? Because during these long flights, if any of y'all's ever been there, you're just sitting there for hours with that change in elevation. So fluid and sodium retention occurs, and it takes about 2 days for you to return to normal from that sodium retention and fluid retention. If you're on a kind of a longer flight, if you were on you were changing planes and you were flying all day, it takes you about 2 days to come back from that, okay? So we want to make sure we're communicating these things to our patients so that they understand what not to do before their lab results, because we want their lab results to be really what they see on a daily, weekly, monthly basis, not just some isolated incident from these certain things. We all know that age changes things. The lab results you get from infants is going to be different than a 90-year-old lady, right? So we want to make sure that we understand our stages of life and our age do affect our results, okay? Mastectomies. We talked about this, right? That we never want to draw blood on the side of a patient who's had a mastectomy, okay? And we understand a mastectomy is when they surgically remove a breast, okay, when they find some form of cancer in that breast. Not all the time, depending on the type of cancer and the stage that it's in, but a lot of times they will also remove lymph nodes in that, under that arm and near that breast, which then your lymph is what helps you keep swelling down. It keeps that tissue fluid moving. So without that, they have a lot of swelling in that arm, which means they're much more prone to infection. Okay, so make sure you read over this and understand what you need to do. Also make sure that the doctor is always consulted, okay, before you do certain things. If you run into a patient that's had a double mastectomy, I mean, just ask. Make sure that you're touching base to make sure you know what they want you to do, okay? So here's another thinking question. Make sure you analyze this out so that you'll know what to do when you're out in the field. Okay, then talking about edema or swelling. If you'll look at this picture, you see that kind of white indented area right there that looks like a circle. That's where you can see some edema showing up. You always want to avoid drawing blood from any area that you can see that is visibly swollen, okay? Because that fluid can contaminate your specimen and give you erroneous results. The menstrual cycle. Okay, we understand that that's why we have different hematocrit results and sometimes hemoglobin results for women versus men, because women go through their menstrual cycle, okay? And it's also a big cause of iron deficiency anemia in women, okay? So the phlebotomist needs to be careful not to collect more blood than absolutely necessary. And we talked about understanding that we need to watch this when we're talking about infants and newborns, children, and people who may be borderline anemic or anemic. Interfering are drugs and other substances in the blood, okay? We have to understand that there's a lot of over-the-counter drugs and things out there that patients take, supplements and things of that nature, and we have to understand that these things can affect our lab results. They can also affect sometimes how long the patient's bleeding, if they're taking a lot of aspirin or things of that nature, okay? So anticoagulation drugs, we need to look at those like warfarin, Coumadin, and heparin. It will cause abnormal bleeding, so the phlebotomist should take extra care to ensure that that bleeding has stopped, okay? And never leave a patient unless you know that bleeding has stopped. You always let a nurse know if they don't stop bleeding because they're on one of these drugs. Also, things that can interfere that are in our blood is nicotine from tobacco and alcohol consumption. So we want to make sure that we understand that, especially in our hematology results. And any information that we get needs to be recorded on our requisition slip if you notice it. So also dealing with infections. Okay, as we know with the COVID-19 thing going around, it's easy to spread infections. And we talked about nosocomial infections inside a hospital. And we know that that's an issue that as healthcare workers, we have to be very careful to wash our hands religiously, to change our gloves, and to make sure that we're not transferring a germ from one patient's room to another, okay? Unfortunately, we have patients that get nauseous when they're having their blood drawn, and sometimes they actually vomit. It's an unpleasant thing, but it happens. Sometimes just the sight of blood can lead to nausea and cause that. That's why you want to keep an eye on your patient as you're drawing their blood. When you talk to them, notice if they're breathing heavy. Notice if they're starting to break out into a sweat, okay? Pay attention to your patients. Okay, so we went over that, having to do with the things that can go on with the vomiting. And make sure that you understand, getting them to take deep breaths and using that cold compression on their head can really help. If they're feeling nauseous, things like that can stop it before it starts. And the last thing you really want to deal with is somebody throwing up on you or near you. Okay, so dealing with other factors affecting the patient, their gender. We talked about this earlier, males and females with hematocrit results and things of that nature. Pregnancy, obviously. Because can you imagine when these ladies come in, they're pregnant and they haven't had anything to eat all day, they're fasting, they have to drink that nasty glucose stuff. We've talked about that before. They feel sick. Geographic regions, we talked about this, about while different regions have different normal value ranges, because things like the altitude, the temperature, and humidity can affect your range for things like your hematocrit, your RBC counts, and things of that nature. So make sure that you record any of this information on their requisition slip. We want to keep up with all the stuff. Okay, so talking about things that may cause you not to be able to collect your specimen. Failure to draw blood, right? Sometimes you don't stick the needle in deep enough. Or either you get it in there, but then when you're moving around, and then when you're new to this, we notice when we're in there about steadying that hand, right? That dominant hand that has the needle in there. So sometimes you just have to make a very minute, small movement and kind of move that needle back in very slightly. And sometimes you've gone all the way. If you see this document down here at the bottom, or this image down at the bottom, the needle has gone all the way through the vein. So sometimes you can make that small, minute movement of easing that needle back out, okay? Also, we talked about how that bevel, if you see from this image here, the bevel can suck up against the inside of the wall and you're not getting any blood coming through there. Sometimes if you just kind of get them to move their arm or kind of bring your arm up a little bit, move your elbow up, it'll loosen up that suction and the blood will start to flow. We talked about how we don't want that backflow of anticoagulants, and that when you position in your tube, make sure that that anticoagulant, that liquid, like the sodium citrate that's in that light blue top, or the heparin that's down in the bottom of the green top, or the EDTA that's in the bottom of the purple top tube, you don't want to hold it where that fluid is going towards the front of the tube and it's on your inner needle that punctures the inside of your vacutainer tube, because then it can get on that needle, and then when you take the purple top off and put like something else on there, that anticoagulant can go into that next tube. So we want to kind of avoid that. Fainting. You are going to run into this. People are going to faint, okay? Again, this is why we want to keep an eye on our patients, right? Are they sweating? Are they pale? Are they breathing funny? Okay, that's why we always want to make sure they're comfortable and they're safe when we put them in that chair. You know how I always tell you, lock them in, right? Because we're trying to do all we can to keep them as safe as possible and avoid any type of injury. And also, you always want to alert somebody if they do faint and make sure that you get them in a recumbent position, okay? If you see that they look like they're about to faint, you see it in their eyes, they're not responding to you, they've got sweat on their brow, their upper lip, they're turning real pale. What your job is to, as soon as you can, get that tube off that inner needle, pop that tourniquet, and get that needle out of their arm, okay? Sometimes if you'll get that patient to lower their head down between their legs and take some deep breaths, hold it and let it out, then maybe that will pass and they won't actually faint, okay? And we should always make sure that patient sits there for about 15 minutes and somebody's kind of watching over them during that time, okay? And if you need to, you can go get a nurse or someone to come in there and watch over that patient if you have to leave and go to another patient. Also, if you're in an outpatient setting of any type, you never want that patient to go home until they feel good. You make sure you want to sit there for at least now, 30 minutes before you allow them to leave and go drive their vehicle. Here's another one of our critical thinking slides. Like I said, pause it, make sure you're putting all this together. If you have any questions, please reach out to me. Okay, hematomas, right? We saw some pictures in our textbook on these hematomas, and it's usually when you have went through that that vein and the blood has leaked out the backside, if you went too far with the needle, if you left the tourniquet on after you brought the needle out, if you didn't hold pressure long enough. There's lots of things that can cause hematomas, and we really want to make sure we do all we can not to cause those. Okay? And here's a list of other things that can cause it, like probing around in that vein, which is something we never do. Now, sometimes if you have an elderly patient that has real fragile veins, that's why we're very careful about the size of the vacutainer tube we use in comparison to the needle size. That's why when you're using those really small 23 gauge needles that's on a butterfly, you don't want to use those really big 10 milliliter vacutainer tubes. You want to move to a smaller one because it can blow that vein and then cause a hematoma. Okay, here's another one of our critical thinking slides. Okay, still talking about hematomas, okay? We should never bend that arm up at the elbow after blood collection, okay? We know we used to see people do that, hold pressure, and then they bend their arm up, right? We don't want to do that anymore. We found that is one of the things that can cause that, right? So make sure they get their arms straightened out, okay? And we want to make sure we hold pressure, right? Okay, petechiae, we talked about this before, right? That's those little small red dots all over. It's a little hemorrhaging that has gone on under the skin, okay? It's usually a result of thrombocytopenia, okay, which is a low platelet count, and this is one that medical terminology comes in to play. Medical terminology is a really great asset for you guys to use to break these words down so you'll kind of know what they mean just by the parts of the word, okay? And this is a warning sign to you that they may bleed excessively if they have a lot of petechiae. So that's something you want to look out for. But always make sure that you peek under there and make sure they've stopped bleeding before you put your Coban on, because you don't want to leave them where blood's running down their arm. Okay? There's patients on any time of anticoagulant therapy, like the warfarin or the Coumadin or the heparin. Also, if they're taking any high dosage of different types of arthritis medicine, it can make them bleed for a longer period of time. That's why we want to do that medical interview and ask them if they're taking any type of medications. Some of the medications they tell you is not going to matter, but you're looking for these ones that will cause these issues. Again, one of our critical thinking slides. Okay, dealing with nerve complications. This is something that can occur. You always want to make sure if there's any incident with that patient, from them fainting, if they have a seizure, or if they report any kind of tingling or pain or sharp radiating pain down in their arm, and that you feel like you may have possibly hit a nerve. That's why we do all we can at selecting the proper vein so we can avoid that. Then you want to make sure that you fill out an incident report and report this to your supervisor. The minute they start complaining of that, you want to immediately remove that tourniquet, get the needle out of their arm, and then get an ice pack and apply it to the area. And like I just said a second ago, seizures. The main thing with seizures is, again, you want to make sure you're paying attention to your patient. Guys, I know it's easy to do this, you stick 30 patients in a day, you're not paying attention. It's like I told you, it's customer service. make sure that you're holding a conversation with them, because if they stop talking, you need to look at them. Are they pale? Are they broken out into a sweat? You know, if they're not responding to you, then you need to get that tourniquet off and get that needle out, okay? Get them laying down in a position. Make sure you get help from someone. Push, if you're in their hospital room, push their button. And you don't want them anywhere where they, if they're having a seizure, your main job is to make sure they don't hit anything. They don't hit their head against something. Okay, talking about hemoconcentration. Okay, you guys need to, we've talked about this. Okay, and it comes from pumping that fist too much and leaving that tourniquet on your arm for too long. Okay, all right. Intravenous therapy. Okay, every time an IV catheter is used, vein damage occurs every time. Okay, circulatory blood is rerouted to the collateral veins, and this can result in hemoconcentration. Okay, that's why the arm with the IV should not be used for venipuncture, because the specimen will be diluted with IV fluids. Okay, so we always want to do that. Remember, we never draw above that IV. And there's processes you go through if you are going to get any blood out of that IV, near that IV site. We always want to use another site if possible. This is some more information here. Okay, like I said, never draw blood above an IV. And you also want to stop that IV, disconnect it, and you want to collect 5 milliliters of blood, and that's discarded. And then the blood you draw after that's the blood you use for your blood specimen. So make sure you read through this slide carefully and understand what you're supposed to do. Guys, make sure you do these thinking slides like we talked about, okay? Because this will really let you know if you're actually putting all this stuff together that you're learning in class, so that you can effectively use this out in the field to make sure you can critically think through these situations that you come into, okay? Hemolysis. We've discussed hemolysis before, right? That's a result when those RBCs tear apart, right, and are destroyed, and hemoglobin's released. And then your serum goes from its normal straw-colored to being tinged either pink or red. And remember, we have it where it's no hemolysis, slight, moderate, and grossly hemolyzed, okay? And remember, it can falsely increase our results, especially that potassium, okay? But there's other things too, so make sure that you know all the tests that it affects. But it's going to affect that potassium the most. And here's a list of all the common things that cause hemolysis during blood collection. Because remember, we talked about in vivo and in vitro, right? These are the things that you can cause if you don't do them correctly. You cause hemolysis in your specimen. So remember, in this chapter, we talked about our basal state. We talked about fasting and the differences between fasting and our basal state. We also talked about all our complications that we run into from drawing blood, from morbidly obese patients to patients that have had mastectomies, all the way down to hematomas and petechiae. So guys, chapter 9, 10, and 11, watch these videos, fill out your study guides, start studying. Also, make sure you're filling out your case study number 2, because we're going to turn that in. And then I'm going to send out an email soon about your lab stuff that's going to come up soon. Hang in there and email me if you need anything. You guys have a great day.